Workshop on Cardiomyopathy. Sharon Chi MBBS, FRAC, PhD. Assistant Professor, University of Ottawa. January 14, 2016. Learning Objectives. Recall and identify the pathophysiology of myocardial diseases and cardiomyopathies. Define and classify cardiomyopathies. Describe the etiology, pathology, pathophysiology, clinical findings, physical exam, diagnostic studies, treatment, and prognosis of the following: dilated cardiomyopathy, hypertrophic cardiomyopathy and restrictive cardiomyopathy. Outline cardiomyopathy versus heart failure. Classification of cardiomyopathy. Morphologic types. Dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy. Cardiomyopathy, WHO definition: heart muscle diseases of unknown cause, differentiating from cardiac dysfunction due to known cardiovascular causes, e.g. IHD, HTN, valvular. In 1980, the World Health Organization, WHO, defined cardiomyopathies as heart muscle diseases of unknown cause to distinguish cardiomyopathy from cardiac dysfunction due to known cardiovascular entities such as hypertension, ischemic heart disease, or valvular disease. 2. In clinical practice, however, the term cardiomyopathy has also been applied to diseases of known cardiovascular cause, e.g., ischemic cardiomyopathy and hypertensive cardiomyopathy. Cardiomyopathy, AHA definition: heterogeneous group of diseases of the myocardium associated with mechanical and/or electrical dysfunction that usually, but not invariably, exhibit inappropriate ventricular hypertrophy or dilation and are due to a variety of causes that frequently are genetic. Further categorized into primary, genetic, mixed, acquired. Secondary. Circulation 2006 113, 1807–1816. Primary versus secondary. Primary cardiomyopathy, secondary cardiomyopathy. Clinically relevant disease process solely or predominantly affects myocardium. Secondary cardiomyopathy. Pathologic myocardial involvement is part of generalized or systemic disorder. Contemporary classification scheme developed for cardiomyopathy moves away from the etiologic classification, but considers the importance of genetic factors in developing disease. Also includes conditions in which electrical activity is impaired, but heart muscle okay, now thought of as SM, but in the past this was not so. Primary cardiomyopathy. Genetic, HCM, ARVC, LV non-compaction, glycogen storage, CAG2, Danon, conduction defects, mitochondria, ion channel, LQTS, Bergada, SQTS, CVPT. Mixed, DSM, restrictive. Acquired, inflammatory, myocarditis, stress, Charcot or tachycardia-induced, infant diabetic mother. We will spend some time talking about the most common types of primary SM, HCM, DSM and myocarditis. Secondary cardiomyopathy. Infiltrative, amyloid, Gaucher, MPs, Hunter-Hurler. Storage, Fabry, Pomp, Niemann-Pick. Toxic, drug, metal, chemical. Endomyocardial EMF, Loeffler's. Inflammatory, sarcoid. Cardiofacial, Noonan. Endocrine, DM, thyroid, parathyroid, Theo, acro. Neuromusk, Friedrich, Duchenne, Becker, Emery, myotonic. Nutrition berry, selenium. Autoimmune, SLE, dermato/poly, sclero, RA. Cancer therapeutic, Adria, radiation, cyclophos. Lights. Important to understand that CAD, valvular heart disease and systemic HTN can all produce secondary changes of dilatation and hypertrophy of the chambers. These diseases need to be ruled out before one diagnoses the patient with a myocyte disorder. This classification scheme refers to patients with a primary myocyte disorder, either muscle cell or cell wall signaling. Cardiomyopathy, Moshe's classification. Phenotype-genotype-based nomenclature, WHF, 2013. Morphofunctional, M, notation indicates a descriptive phenotypic diagnosis, e.g., MD equals dilated cardiomyopathy. Organ involvement, O, notation indicates if heart and/or extracardiac involvement is present, e.g., O plus K equals heart and kidney involvement. Genetic or familial inheritance, G, notation indicates the nature of genetic transmission, e.g., GAD equals autosomal dominant. Etiological annotation, E, provides description of the specific cause, e.g., the specific gene and mutation as in e.g. my7p.arg403 GLU. Functional status, S, term is considered optional, e.g., SC2 equals stage C disease in New York Heart Association functional class 2. Clinical applicability. Definition, heart failure. Condition where the heart cannot pump an adequate supply of blood at normal filling pressures to meet the metabolic needs of the body. Clinically, reduced cardiac output, congestion, impaired quality of life, reduced life expectancy. Complex syndrome in which abnormal heart function results in, or increases the subsequent risk of, clinical symptoms and signs of low cardiac output and/or pulmonary or systemic congestion. Cardiomyopathy characterized by ventricular dilatation, hypertrophy. Frank-Starling, CO equals SVXHR. Laplace, tension equals press x rad/2x thick. Int of the cause of the damage. There are several responses to injury for the heart. The most common is dilatation of a chamber and hypertrophy. Fibrosis can occur, but more specifically in myocardial infarcts. Hypertrophy refers to increased muscle cell mass. Cellular hypertrophy implies that the weight of the heart is increased, usually reflects an increased afterload or preload. Dilatation refers to increase in size of the chamber, due to increased preload or volume overload. Heart failure, increased contractility. Normal heart failure. Stroke volume, cardiac output. A. Heart failure. B. C. In a normal heart, cardiac output increases as a function of preload. Decreased LV contractility is characterized by a heart that is shifted downward. Point A is normal person at rest. Point B is the same person after developing systolic dysfunction. Stroke volume has fallen, decreased LV emptying, and the LVAD has increased. This increase in EDV is compensatory, on the ascending part of the curve, because it will increase SV for the next beat. But further augmentation in LV filling in the heart puts patients on C, where SV is not increased but symptoms of pulmonary congestion develop. Hypotension, pulmonary congestion, left ventricular end diastolic pressure, volume. Symptoms and signs of HF. Increased filling pressures, poor cardiac output, congestion, poor perfusion, congestion left-sided right-sided symptoms signs dyspnea, orthopnea, paroxysmal nocturnal dyspnea, fatigue. Signs: S3 gallop, displaced apex, Mr. Pulmonary rails, loud P2, right-sided. Symptoms: peripheral edema, abdominal bloating, nausea, anorexia. Signs: elevated JVP, hepatomegaly, ascites, edema. Assessing perfusion symptoms, signs: fatigue, confusion, dyspnea, sweating, hypotension, tachycardia, cool extremities, altered mental status, rising creatinine, liver enzyme abnormalities. Classification of cardiomyopathy. Multiple ways to consider classification. Etiology: systolic versus diastolic, right versus left. Anatomic: general causes of heart failure and cardiomyopathy. Coronary artery disease, myocardial infarction, valve disease, idiopathic cardiomyopathy, hypertension, myocarditis, pericarditis, arrhythmias, thyroid disease, pregnancy. Mechanisms and causes of HF: impaired contractility, myocardial infarction, transient ischemia, chronic volume overload, Mr/R. Dilated cardiomyopathy, increased afterload, as uncontrolled HTN, systolic dysfunction, left-sided HF, diastolic dysfunction, impaired ventricular relaxation, LVH, hypertrophic cardiomyopathy, restrictive cardiomyopathy, transient ischemia, obstruction of LV filling, MS, pericardial constriction or tamponade. Mechanisms and causes of HF: cardiac causes, left-sided HF, pulmonary stenosis, right ventricular infarction, right-sided HF, parenchymal pulmonary disease, COPD, interstitial lung disease, chronic infections, adult respiratory distress syndrome, pulmonary vascular disease, pulmonary embolism, pulmonary HTN, right ventricular infarction. Anatomic classification: dilated, hypertrophic, restrictive, dilated cardiomyopathy. This heart came from a 24-year-old male student with no known PMHX. He presented with SOB. Heart is dilated, both LV and RV, as well as hypertrophied. Dilated cardiomyopathy. Dilatation and impairment of contractile function. F less than 40%. Idiopathic if CAD excluded. Non-ischemic DISM. What are the causes of DISM? Idiopathic, 50%, familial. Substance abuse, 3%. Myocarditis, 9%. Infiltrative disease. Peripartum, 4%. HIV, 4%. Chemotherapy, 1%. Tachyarrhythmias. Electrolyte imbalance. Nutritional, thiamine, scurvy. DISM clinical presentation. Progressive heart failure. Systolic dysfunction. Four-chamber dilatation. Hyperkinesis, global or segmental. Arrhythmias. Thromboembolism. Sudden death. Enlargement of all four chambers. Heart assumes a more spherical shape. Gross pathologic findings. Enlargement of all four chambers. No significant CAD. Normal valves with regurgitation. Enlargement and distortion of the subvalvular apparatus. Intracavitary thrombi. Myocyte changes, pressure overload, concentric remodeling. increase in myocyte cross-sectional area with no increase in length. Leads to increase in wall thickness, increase in ratio of wall thickness to chamber dilatation. Volume overload. Both volume and wall thickness increase. Eccentric remodeling. Increase in both myocyte length and cross-sectional area. Myocyte length is the major determinant of changes in LV size. Most of major increase in LV volume can be explained by an increase in myocyte length. Other myocyte finding is apoptosis, programmed cell death. Molecular changes in cytoskeleton lamin, emeridre fus. Desmin. Vinculin. Actin. Dystrophin, X-linked. Sarcoglycans. Mitochondrial. Molecular biology has shown us that in many of these cases of primary dilated cardiomyopathy the abnormality is with the cytoskeleton of the myocytes. Other research indicates there are problems or susceptibility to free radical myocyte damage or increased apoptosis of the myocytes. Many of these primary dilated cardiomyopathies are inherited. This is another form of myocardial injury? What is happening here? Myocarditis. Demonstrated inflammatory cell infiltrate, resulting in destruction of normal myocardial cellular apparatus. This slide was taken from an 18-year-old male who died suddenly when playing basketball. The interstitial lymphocytic infiltrates shown here are characteristic for a viral myocarditis, which is probably the most common type of myocarditis. Many of these cases are probably subclinical. Some may be a cause for sudden death in young persons. There is usually little necrosis. The most common viral agent is Coxsackie B. This is a gross photograph of the heart from which the last slide was taken, opened at autopsy. The heart has many similarities to that of the last case of dilated cardiomyopathy. This heart is dilated and flabby. The myocardium seems pale due to inflammation and edema. Myocarditis infectious, non-infectious, systemic. Viral, Coxsackie B, echovirus, EBV, cytomegalovirus, HIV, Hep C. Bacterial, TB, diphtheria. Non-infectious. Hypersensitivity, antibiotics, lithium. Systemic. Sarcoid, celiacs, Wedners. Myocarditis can be infectious or non-infectious. Infectious most common. Most often infectious causes. Management of dilated cardiomyopathy. Early treatment. Remove precipitating agent. Diuretics and vasodilators as needed. Role of steroids/anti-inflammatory therapy controversial. Fulminant cases may require mechanical support. Long-term management. AK/ARB, beta blockers, aldosterone agents etc. Prevention of complications. Routine anticoagulation not indicated. Referral for ICDS when appropriate. Hypertrophic cardiomyopathy. Hypertrophic SM. Hypertrophic SM. Due to a variety of conditions resulting in increased wall thickness and mass. The left ventricle is markedly thickened in this patient with severe hypertension that was untreated for many years. The myocardial fibers have undergone hypertrophy. This is from a patient with long-standing chronic systemic arterial hypertension. What is the abnormality shown? Cardiac hypertrophy. What valvular lesion might result in a heart which looks similar to this? 3 causes of AS, age-related degeneration, congenital, bicuspid and post-inflammatory, rheumatic. Aortic stenosis, cardiac hypertrophy. What would be the functional effect of having a ventricle like this? Diastolic dysfunction. Ischemia from increased demand. Here the heart is cut at a slightly different plane. What are the structures seen here? What is the major abnormality and where is it located? Asymmetrical septal hypertrophy. WHO definition. Left and or right ventricular hypertrophy which is usually asymmetric and involves the interventricular septum. Inappropriate ventricular hypertrophy without a cardiac or systemic cause. Clinically results in poor left ventricular filling and possible left ventricular outflow obstruction. Pathology: increased wall thickness causing increased LV mass. Pattern of hypertrophy: asymmetric in 2/3. Remainder: concentric, apical, abnormal MV, elongated leaflets, anomalous insertion of pat muscles, myocardial fibrosis. Small percentage develop dilatation and wall thinning, 3 to 5% end-stage HF. Increased LV mass all due to increased wall thickness. Usually a SOC with LA enlargement, elongation of MV leaflets and areas of replacement fibrosis. May see fibrous plaques on the mural endocardium of Leavitt due to contact of MV and septum. Pattern of wall thickening is heterogeneous, areas of normal wall thickness BW hypertrophy. Discuss Japanese apical variant, very uncommon outside Asia. Maron classification. Maron classified asymmetric septal hypertrophy into 4 types. Also asymmetric apical hypertrophy, Asian Peats, T-waves greater than 10 mm, a soft spades configuration of LV gram. Midventricular obstruction, midcavitary obliteration in systole. HCM phenotype is not always expressed as a thickened LV, some patients have mild thickness and some genotypically affected individuals have normal thickness. Limited applicability with knowledge of genetic basis of HCM. Apical hypertrophy not initially described. Maron et al., AMJ Cardiol 1981 48 to 418. Microscopic disarray: loss of normal parallel arrangement of myocytes. Abnormal intercellular connections. Variation in diameter and length of myocytes. Within cell variation. Abnormal intramural arteries. Disorganized cells may impair normal intercellular transmission of EP impulses. Most common abnormality: myocyte disarray. In cells, varied nucleus size, disruption of myofibrillar architecture. Increased connective tissue, myocardial fibrosis. Small arteries characterized by medial hypertrophy and small lumens. 4 common things. Disarray of myocytes seen in 95% HCM peats who die from disease. Replacement fibrosis. Expansion of interstitial matrix collagen compartment. Abnormally small intramural arteries, all described in Italy by Tier. Genetics: prevalence 1 in 500, autosomal dominant, variable penetrance. Identifiable genetic mutation in 60 to 70%. Main defect is in genes encoding for sarcomeric proteins. B-myosin heavy chain, CHRM14Q11. B-cardiac troponin T, CHRM1Q3. Cardiac troponin I, CHRM19P13.2Q13.2. Alpha-tropomyosin, CHRM15Q2. Cardiac myosin binding protein C, CHRM11P11.2. Essential myosin light chain, CRP. Regulatory myosin light chain, CHRM12Q2. Molecular biology has found that the disorder is due to mutation in the contractile and sarcoplasmic proteins of the myocyte. These include myosin, tropomyosin and troponin. Multiple mutations have been described and are associated with a different prognosis. Genetics: most mutations are missense. Single normal AA replaced for another, which alters functional properties of protein. 30% of cases due to mutations in cardiac MHC gene. Major mutations affect the polypeptides crucial to the structure of myofibrils and result in myofibrillar disarray characteristics in HCM. 15% due to mutations in cardiac troponin T. 15% due to mutations in myosin-binding protein. MHC, myosin heavy chain. Cardiac sarcomere. Need to review. Hypertrophic cardiomyopathy, structural/functional abnormalities. Diastolic dysfunction. Dynamic subaortic obstruction. Mitral insufficiency. Myocardial ischemia. Clinical presentation of HCM. Exertional limitations. Chest pain, subendocardial ischemia. Heart failure, diastolic dysfunction. Presyncope/syncope. Palpitations/arrhythmias. Sudden cardiac death, 1%/year. Why might HCM patients present this way? Give a pathophysiologic explanation for each symptom/sign. HCM sudden death, young age, family history, SCD. Certain mutations. Myosin ARG 403 GLN. Marked LVH, greater than 30 mm. Non-sustained VT Holter. Unexplained syncope/resuscitated cardiac arrest. Stress testing, blunted BP response, arrhythmias. LGE on SMA. HCM treatment, medical B blocker, calcium channel blocker, disopyramide. Avoid positive inotropes, vasodilators, dehydration. Maintain senior. ICD for prevention of SCD. Alcohol septal ablation. Avoid competitive sports. Surgical. Myectomy. Transplant. HCM. What other processes could mimic this disorder? Hypertension. Amyloid. Athlete's heart. Age-related changes. Aortic stenosis. Athletic heart characteristic, athletic heart HCM pattern, LVH. Concentric. Asymmetric. Septal size. Less than 13 mm. Greater than 15 mm. LA size. Normal. Dilated more than 4 cm. LVED. Greater than 45 mm. Less than 45 mm. Diastolic function. Abnormal. ECG. LVH. LVH plus Q waves, scent depressions, TINV. Elite female athletes have LV thickness from 6 to 12 mm. Athlete's heart. More commonly in men. May require period of detraining for 4 to 6 months. CV symptoms or positive family history, premature sudden death. Look for Q waves, scent depressions and deep T inversions. Less than 2% athletes have wall thickness greater than 13 mm. Restrictive cardiomyopathy. Restrictive cardiomyopathy. Restrictive cardiomyopathy. Distinct morphologic and hemodynamic characteristics. Non-dilated ventricle. Rigid ventricular walls. Normal left ventricular systolic function. Restrictive SM. What are the hemodynamic consequences of this disease? Severe diastolic dysfunction. Poor left ventricular filling. Elevated left-sided filling pressures. Dilated atria. Restrictive SM. What are some causes of restrictive SM? Amyloidosis. Sarcoidosis. Hemochromatosis. Chemotherapy. Endomyocardial fibrosis. This is a case of amyloid involvement of the heart. Amyloid is a type of protein that may be deposited preferentially in the myocardium, for unknown reasons. Some cases are related to multiple myeloma, plasma cell malignancy, while other types are post-inflammatory or genetic. Clinical presentation. Incidence increased in elderly. More common in women than men. Present with HF, congestion and reduced cardiac output. Dyspnea. Edema. Exercise intolerance. Failure of cardiac output to increase with an increase in heart rate without further compromising ventricular filling. Can have advanced RHF. Disease-specific clinical presentation. Amyloids. ATTR, senile or inherited, or AL. Rapid progression of HF. Conduction blocks. Systemic signs amyloid, neuropathy, orthostatic hypotension, macroglossia, abnormal nail beds, periorbital bruising, disease-specific clinical presentation. Hemochromatosis. HF. Arrhythmias, heart block. Systemic signs of abnormal iron deposition. Sarcoidosis. Ventricular arrhythmias. Management specific to underlying cause amyloid. Generally poor prognosis for AL. Liver transplant for ATTR. Chemotherapy plus/BMT for AL. Sarcoid. Possible role for steroids. Hemochromatosis. Iron chelation therapy. Phlebotomy. Summary slides. Cardiomyopathy dilated's most common. Refers to dysfunctional myocardium. Mechanical or electrical. Primary or secondary. Pathologically classified into 3 types. Dilated's most common. Dilated with or without some hypertrophy. Need to consider multiple causes. Aggressive treatment of SME even in absence of HF. Summary slides. Hypertrophic. Hypertrophy with or without some dilatation. Hypertrophy can result from HTN or AS. Primary cardiomyopathy is genetic abnormality of contractile subunit. Risk of HF, arrhythmias and SCD. Restrictive. Impaired filling without dilatation. May have some hypertrophy. Infiltrative sarcoid, amyloid and hemochromatosis. Pericardial disease. This is the pericardial surface of the heart. The surface should normally be smooth, but how would you describe it? Rough, hemorrhage, exudative material, fibrin strands. This is called fibrinous pericarditis. The epicardial surface of the heart shows a shaggy fibrinous exudate. The epicardial surface of the heart shows a shaggy fibrinous exudate. This is another example of fibrinous pericarditis. This appearance has often been called a bread and butter pericarditis, but you would have to drop your buttered bread on the carpet to really get this effect. The fibrin often results in the finding on physical examination of a friction rub as the strands of fibrin on epicardium and pericardium rub against each other. Pericarditis etiology. Idiopathic. Infection. Viral. Bacterial. Rickettsia. Fungal. Worm. Protozoa. Autoimmune. Tumor. Drug, toxin. Trauma. Radiation. Acute me, Dressler's. The inflammatory reaction with pericarditis is often accompanied by the accumulation of fluid in the pericardial space. This is called pericardial effusion. Complications of pericarditis. Causes of pericardial effusion. Malignancy, 25%. Infection, 27%. Collagen vascular disease, 12%. Radiation, 14%. This is an example of TB pericarditis. How would you describe this abnormality? Caseous necrosis. What other pathology does this patient's heart show? Old inferior transmural LV myocardial infarct. TB pericarditis associated with TB elsewhere in the body. Can present with multiple stages. Dry stage, isolated granulomas in pericardium. Effusive stage, effusion. Absorptive phase, symptoms resolve as effusion is reabsorbed. Constrictive phase, thickening of pericardium. This is a lateral CXR on same patient. What is abnormality? Calcification of pericardium. What physiologic effect might this have? Constriction or poor filling of the heart. This is called constrictive pericarditis.